A little about our health system. So we are in Kansas City, Kansas, between KCMO, Go Chiefs, and KCK. We were founded in 1906, but became a public authority in 98. We have over 1,000 beds and 80 facilities providing care. We have several service lines that are listed there for your information. As far as FY22 volumes, you can see there we had 64,000, almost 65,000 discharges. We had over 1 million ambulatory clinic visits and a bunch of outpatient encounters, et cetera. We have over 13,500 employees, lots of accreditations. We've been magnet designated on the inpatient side since 2006, and just a few years ago achieved that on the ambulatory side as well. And in 2022, we became a comprehensive cancer center. So some of our learning objectives today, I won't read them to you, but we all know, and it's kind of been a theme throughout the conference, of how the heck do we do an informatics staffing? How do you staff an informatics team? Nobody knows, there's no research out there. We found the same thing, as did others of you that I've heard in talks that we've been throughout the last couple of days. So we have a team support model, which you'll hear a lot about today, and we will describe the benefits of that to you. We want you to understand our future state informatics structure that is constantly changing still, because we haven't figured it all out, but we've figured out some things. Outlining a methodology for how we overcome those barriers, and then sharing some KPIs with you. I won't bore you with our outline, but there it is. So from a background perspective, we were originally formed through University of Kansas physicians. So our health system, before it was a public authority, and even still now, there's UKP, who the physicians work for, and then there's the health system, and then there's the college. So it's kind of like a triangle. And our team and the Epic, we are an Epic institution. So when we installed Epic, UKP said, gosh, we need some people to support our providers. Let's hire some folks to be in clinic, do that day-to-day support. It was 8 staff supporting 1,000 providers in 70 clinics. So that's the other thing to know. Rachel and I are mostly ambulatory, though we do inpatient provider onboarding as well. So we do a little bit of everything, but we're mostly in ambulatory. Our team at the time was assigned to specific divisions. Rachel was OB-GYN. There was another person assigned to pediatrics. And
actually, I had both OB and peds.
She had both OB and peds, stand corrected. But we had 8 different people assigned to divisions. And though we tried to do some things the same way, we really didn't. And so we were really that liaison for break-fix problems and in-the-moment support, not really looking at workflow analysis, how to make things better, et cetera. We were really just focused on how do we convert to the Epic EMR.
Yeah, so then when we were looking at the business need and the health system was growing and we were no longer UKP, health system, ambulatory, we were trying to be a holistic enterprise. They wanted to have some standard workflows, and an office visit should be an office visit in a surgical place, no different than ENT from ortho. So we really needed to have some operational initiatives that we needed to help drive, and we needed to develop some KPIs. When we were first going live, it was just, we got to get everybody up on Epic, and we weren't really looking at, are we making changes that are really improving outcomes, improving patient care, improving experience, any of those things. Our providers were getting back to us and letting us know that they were not having great experiences. They were getting and feeling the burnout as well. So we needed, as an informatics team, to shift. And so not only are we an informatics team, but we also share the extra hat of being operations. So we help in those operational decisions and help in those governances to kind of help facilitate and say, okay, this is the way we should do things. This is the industry best practice. So our team had to grow. And as Erin said, we started as 8. We are now a team of almost 28, covering all of ambulatory. We also support about 40 system applications as well as Epic. Those are listed in the appendix.
Okay, now these are where Rachel wants me to hurry up because I say a lot of words. So I'm going to try and keep it basic and answer questions later so we make sure we get through all the content. So hearing all that background and where we came from and kind of now going, where do we want to go? So we were super complex. We had inconsistent processes. The onboarding of providers was very inconsistent and actually done by our IT team. without kind of that operational layer of it. One AOI member, that's what we call ambulatory operations and informatics. So when you hear AOI, that's what that means. Our team really started doing more and more projects as well. So less just end user support, but more they would come to us and say, hey, there's this new thing Epic has come out with. Will that improve your operational workflows? And needing us to kind of be that liaison, which is where informatics fits in. We did onboarding and then clinic initiatives as well. I want to move this printer from here to over there, and we would help them. You know, you own all the printers, you own all the workflows, you own all the doctors, you own everything in informatics. We wanted to move it to a future state that aligns with work areas and level loads our assignments. And the future state as well should align with the health system vision. So at a director and VP level, we set the vision for the fiscal year of what we're going to work on. And the informatics team then intakes like optimization requests and says this does or does not align with the health system initiatives, and we communicate back to the end users as such and prioritize them based on that. We do align our work areas with quadrants. So we have primary care, specialties, you know, community and an academic division. We have surgical, OB-GYN, urology, vascular surgery, blah, blah, blah. We have medical, rheumatology, infectious disease. And then our fourth one, like I kind of alluded to, we are mostly ambulatory, but we also do support the hospitalists, especially in the provider onboarding. So this is where it gets sticky and everybody I think is asking questions. What's the ideal staff to workload model? So we're going to talk about this for every role we have. We have 4 different roles, as you can see here. So we have the CTLs, or clinical technology liaisons. We have analysts, we have specialists, and then we have leads. And I'm going to leave it there because we go into each in detail. So our CTLs, or clinical technology liaisons, they teach the initial EMR training to the providers. So to get their Epic access, they teach the classes that the providers need to go through. And like I said, it's inpatient and ambulatory providers. They also onboard them. So for us, your onboarding used to be done after you took your 101 class. And nobody ever talked to you again. We said, good luck, gave them a pat on the back, and said, let us know if you got a problem. And they always had a problem. So we said we should do that better. So we work with them in a course that we call Epically Efficient. But basically, we go in from a proactive approach. We run data out of Epics called a signal report for those of you who are Epic users. But it basically tells us where every single provider maybe has opportunities to improve their efficiency in the system. So we come armed with that and we say, hey, the system tells us you should use more smart phrases. The provider can always say, no, I don't want more smart phrases because I'm using Dragon and I've trained my Dragon to do all the things. And we say, oh, but you can make your Dragon better if you only taught it smart phrases. And so, you know, we kind of go back and forth. So that epically efficient is a marriage of what the provider desires to get out of the session, what we see as proactive information out of Epic and Signal, and just knowing the best practice set up for a fam med physician, because we've done it 75 times. And then we go to them for 14 weeks, sitting with them one-on-one at the elbow. So our CTLs do that. And then they have 30, 60, 90-day evaluations as well. And then we offer it, anybody can take Epically Efficient anytime. We're trying to get to a model where we offer ongoing personalized education. There is literature out there that says you should offer every provider 4 to 6 hours a year of that. It's a little bit hard to get them to engage in that. Our system has not yet given CMEs for it or said it's works so many work RVUs so they get comped for their time, right? That's what they don't want to take time out of clinic because, yeah, even though we could make them faster, which we've proven. But they also are providing proactive support in the clinics. So that also comes from kind of the vision that I was talking about earlier. So we will tell our team, hey, we're focused on these 3 items. We're going to round in every clinic on these 3 items. Maybe it's the stop of the rooming workflow for our timing is putting the exam room number in the rooming navigator. Maybe it's we're going to focus on, I don't know, there's an image viewer change coming, and every single provider needs to hear that. So they're going to the clinic, because what we found was, our old approach was, what do you need help with? They're like, I don't know, I'm busy seeing patients. I have no idea. And so we are trying to come to them with proactive rounding. We also have a super user program that these folks administer. So before every go live, you'll have a couple super user meetings, which we try to dive a little bit deeper into the content. So then it's hopefully a tiered approach of the end user escalating to the super user, who escalates to a CTL, who eventually could get it to an informatics person.